This patient has an unruptured right-sided M1 aneurysm. The aneurysm has actually its base partially at the origin of the cortical M1 branch. The cortical branch is pointing anteriorly, but the actual aneurysm is oriented more laterally. In the surgical projection, the aneurysm will be pointing distally into the sylvian fissure, and it should not be obstructed by any other structures. The optimal approach in this case will be from distal to proximal along the M1 segment. Proximal control should not be a problem in this case. After a right-sided lateral supraorbital approach, we see that this patient does not have a sylvian vein running along the sylvian fissure. The sylvian fissure is entered rather proximally. The aim is to arrive directly at the aneurysm site. Arachnoid covering the sylvian fissure is opened under high magnification, and water dissection is used to expand the dissection plane. The fissure is very tight, so that we have to proceed very carefully to preserve all the vascular structures. Deeper inside, we identify the cortical M1 branch, and just at its origin is the aneurysm. Proximal M1 trunk behind and below the aneurysm is prepared for eventual temporary clip. The M1 trunk continues distally on the temporal side of the aneurysm. Some arachnoid bands are cut to open the sylvian fissure a little more, and the whole aneurysm base is cleared. As we have good control over the aneurysm, we place a curved pilot clip directly over the aneurysm without a temporary clip. Small aneurysm remnant remains outside the clip plates, as can be seen. The aneurysm inside the clip can be safely reshaped with bipolar coagulation. ICG is used to verify that the branch originating at the base is patent, so is the M1 trunk. To get also the aneurysm remnant into the clip, we temporarily place a retractor to hold the temporal lobe out of the way. Temporary clip is placed on the proximal M1, and since the aneurysm is now slack, the whole dome can be pulled inside the final clip. The temporary clip is removed. The flow is checked with microdoppler. There is some spasm due to manipulation in the branching arteries, so we apply papaverine. IgG is done once again. There is still contrast visible from the previous injection, but once the new bolus arrives, we can see that all the arteries are patent and the aneurysm is occluded. Papaverine is applied again. The opening of the sylvian fissure was less than 20 mm. On the postoperative CTA we see patient M1 and the cortical branch.